And I support some quality improvement topics for clinical care management, which I'll explain a little bit about in a moment. One of the topics that I support is the prevention of venous thromboembolism. So this session is actually the second in a series of webinars to support clinical care management for preventing VTE, or venous thromboembolism. And CCM is the largest quality improvement initiative that we've ever undertaken in the province of British Columbia. So we're pretty excited about that, and we're really happy that you've joined us on the call today. CCM is led by a steering committee that consists of representatives from the Ministry of Health as well as reps from all of the health authorities in our province, and it's supported by the BC Patient Safety and Quality Council. And we're very honored today to have two great physician champions for VTE with us today. Both are recognized leaders in VTE prophylaxis. So I'm just going to briefly introduce them before they get started. So Dr. Greg Maynard is a clinical professor in the Division of Hospital Medicine at the University of California, San Diego. And he was joking that he's present in the middle of a very warm, sunny day down there, which we're all jealous of here in BC, I'm sure. That he's the director of the University of California, San Diego Center for Innovation and Improvement Science, which is an entity that's designed to accelerate inpatient innovation, improvement, and leadership locally and regionally. And in addition to clinical and teaching and a QI leadership role at the UC San Diego, Dr. Maynard commutes and communicates frequently with the Society of Hospital Medicine headquarters in Philadelphia, where he's the Senior VP of the Society's Center for Healthcare Improvement and Innovation. His special interests include, among many other things, the prevention and management of VTE, and he's led national collaboratives to improve VTE prevention. He was recently recognized as one of his nation's top hospitalists and has been recognized nationally for his work in quality improvement and research by the Society of Hospital Medicine, the National Association of Public Hospitals, the Venous Disease Coalition, and the North American Thrombosis Forum. We also have with us today Dr. David Wilton, who is the director of the hospitalist program at Vancouver General Hospital here in BC. And he's the current president of the Canadian Society of Hospital Medicine and a founding director of the National Society for Patient Safety. Dr. Wilton has successfully led VTE prevention strategies both at Vancouver General as well as province-wide, and he's the lead physician for the BC Hospitalist VTE Prevention Collaborative, which I'm sure he'll mention later in his presentation. Dr. Wilton joined the BC Patient Safety and Quality Council in January of last year, and he's the clinical leader for VTE Prophylaxis Improvement Initiative for Clinical Care Management. So I'd like to welcome both of them here today with us. Before I hand it over to Dr. Maynard to begin, I just wanted to get a quick sense of who's on the call with us today. So if you look in the top left corner of your screen, you'll see a pointer arrow. Click once on that pointer arrow, and then click on the map and show us where you're calling in from today. I'll just give you a moment to do that. That's great. So it looks like we've got some people from the island. We've got people, looks like from Vancouver Coastal probably, and from Fraser Health. Lots of people from the interior today, and even someone from way up north in Prince George, who I'm sure is envious of Dr. Maynard's placement in San Diego today. It's probably pretty cold up there. And I see that we also have somebody joining us from a province east of British Columbia, so welcome, and I hope that everyone finds something that they find useful today. So just a few things to go over before we begin. All of the audio lines are muted automatically while the presenters are talking. We do have some time set aside later in the call to ask questions and have an open discussion. While our presenters are talking, there's a couple of ways that you can ask a question. And one is, as the presenters are speaking, type your question into the chat feature. And you'll see that on the right-hand side of your screen. You can type your question into chat and click send. And that way we'll record those questions and hold them until our question period at the end of the call, where I'll read them out and direct them to one of our presenters to answer for you. And the other thing you can do during our question period at the end is to raise your virtual hand. So if you could look again on the right-hand side of your screen, you'll see a little hand icon. Click once on that. You can test it out right now. to put up your virtual hand, and then we will be able to unmute your line to ask your question. And if you click a second time on that hand icon, your hand will go down and disappear. Okay, we will move into a question period, like I said, at the end of our call. But right now, I'm going to hand it over to Dr. Greg Maynard. And I will just make you the presenter here so you can advance the slides as you need to. I am just going to mention briefly the objectives today would be to learn techniques for designing and implementing effective VTE prevention protocols. We're also going to understand the use of measure-vention, which is the term we'll come to understand in a moment, to accelerate improvement efforts for VTE. And later we're going to learn some effective auditing techniques for VTE prophylaxis. So Dr. Maynard, go ahead.
Thank you, and thank you very much for having me on the call today. I'm very pleased to be here. So I'll be relaying somewhat of our local experience as well as how that experience got spread and some of how our ideas got modified by interacting with others who are trying to do some of the same work, and how we modified some techniques to make them more generalizable to a broader range of hospitals. I would be remiss if I didn't point out how big of a problem this is and how major of a problem venous thromboembolism is, with an estimate of 350 to 650,000 deaths per year, episodes of VTE per year in the United States, with estimates ranging from 100,000 up to 300,000 deaths per year, depending on who you read, but pretty much all estimates pointing to well over 100,000 deaths per year. Most of those deaths are thought to be hospital-related. Most of the events are thought to be hospital-related. That doesn't necessarily mean they all happen in the hospital. Many of them occur in the first 30, 60 days post-hospitalization, and many people get readmitted from sequelae of venous thromboembolism that had its nidus in the index hospitalization. Of those deaths, the fatalities associated with VTE, VTE is thought to be a primary cause of fatality in more than half. And we have to keep in mind how many deaths this is. This is more than AIDS and breast cancer and motor vehicle accident deaths combined. I think most people just don't understand the scope of how big of a problem venous thromboembolism is and how many people suffer from both the morbidity and how many people are affected by deaths. It's thought to be one of the most common causes of hospital deaths and perhaps the most common preventable cause. Others argue that that might be adverse drug events, but it's definitely up there. And it's not just deaths, of course. It's cost, morbidity, the late sequelae of recurrent DVT, post-phlebitic syndrome, and a small minority, small but important minority, chronic pulmonary artery hypertension. There are, of course, many risk factors for venous thromboembolism. As you look down this list, I'm sure you'll see that, this is just a partial listing and that almost everyone in the hospital has at least one of these risk factors. So the approach might be, well, let's find out who doesn't need prophylaxis and everybody else gets it. And we'll talk about that as a potential strategy, but it is important to realize that most patients in the hospital do have multiple risk for venous thromboembolism, some of which are inherent in their medical profile and some of which are temporary, brought upon them by their visit in the hospital. We have lots of trials around prophylaxis. These are randomized controlled trials looking at prophylaxis in medical inpatients. These three trials all looked at both symptomatic and asymptomatic DVT, so they were screening studies. They show what most studies showed. They showed a 40 to 60% reduction in DVT or PE. In this meta-analysis, it was published in the Annals looked at 9 studies of 20,000 medical inpatients, looked at anticoagulant prophylaxis versus no treatment, and they saw benefit in symptomatic PE, fatal PE, DVT, and no increase in major bleeding. I should say there's been some more recent controversy. This meta-analysis has essentially been redone, and that was just redone using pretty much the same studies. Letterly and company did a meta-analysis using a varied technique. They eliminated some of the outcomes that were included in the prior meta-analyses, and they also saw no increase in major bleeding, but they didn't see as much reduction in DVT. They didn't see a significant reduction in DVT or mortality. They did see reduced pulmonary emboli. And, you know, really the difference between these two studies isn't in the studies that they included, but more in the technique. So I think the pendulum is swinging right at this moment towards a little bit more caution on the medical inpatient, yet the Annals and the American College of Physicians guidelines still called for doing risk assessment as people enter the hospital, and that most of those patients would benefit from anticoagulant prophylaxis when you weigh the risks and benefits. Another study just came out that may add a little fuel to the fire. It was published in the New England Journal. It was a large randomized controlled trial, largely in the third world and in Asian medical inpatients. And it, again, showed no increase in major bleeding, but nor did it show any increase, or I should say, nor did it show any reduction in all-cause mortality I believe the endpoint was 30 or 90 days. However, that study didn't look at symptomatic venous thromboembolism. You know, if you ask the likes of Bill Geertz, he's pretty frank that he doesn't think this has much importance as a piece of literature. For the medical population, or excuse me, for the surgical population, we have probably even better evidence, or probably unequivocally better evidence for DVT prevention using anticoagulants. This is a meta-analysis looking at pharmacologic prophylaxis in colorectal surgery, and everything to the left of the middle line indicates benefit. And so the point estimate here is, again, 60 or 70% reduction in DVT-PE in colorectal surgery, which is one of the higher risk surgeries for DVT. Now, they did show that there's not necessarily much difference between unfractionated heparin and low molecular weight heparin. So depending on your formulary, depending on the cost to you of getting low molecular weight heparin versus unfractionated heparin, depending on how you value once a day low molecular weight heparin versus a 3 times administration a day unfractionated heparin or so, then you know, that's what you hinge your decision on, I think, more than the efficacy of low molecular weight heparin versus unfractionated heparin. Some of the studies do favor low molecular weight heparin, but I think the advantage of low molecular weight heparin is mainly in its convenience to the patient and to the nursing staff and in the time of administration, and in its lower incidence of heparin-induced thrombocytopenia. When we look at adherence, that is, what percentage of the doses are administered, it is better in low molecular weight heparin because it's not as many opportunities to fail, I think. There are some patients in whom you'd want to give both pharmacologic prophylaxis, like a heparin, and mechanical prophylaxis, like graduated compression stockings or sequential compression devices. This is the same study that showed pharmacologic plus mechanical prophylaxis was superior to the heparin alone. And I think that's true in certain populations that include major orthopedic surgery, such as hip fracture repair, hip replacement, abdominal and pelvic surgery, especially abdominal pelvic surgery for cancer. And some people include all critical care patients that are really critically ill and in the ICU in this category as well, though the evidence for that isn't quite as strong. The same Bill Geertz, who I think has already presented in this series, used to be the lead editor for the American College of Chest Physicians Guidelines, which last were published in 2008, which will be revised coming up here probably next month. And their guidelines include that every hospital should have a formal strategy to prevent VTE. They say you shouldn't use aspirin for prophylaxis, and they said mechanical prophylaxis is primarily for patients at high bleeding risk or as an adjunct to pharmacologic prophylaxis, in which case you're using both pharmacologic prophylaxis and mechanical. And it goes on to list the people who you might want to give thromboprophylaxis for, and it's basically most patients in the hospital, I think. Yet we do things not so well. In spite of the guidelines, in spite of the evidence, study after study shows that we have still a long ways to go, and that's why it's the focus of this improvement initiative for you, I think. In this worldwide study, the endorsed study, they found that 60% of patients or less of surgical inpatients were on the right prophylaxis, and less than 40% of medical inpatients. It's a common finding, actually, to find the medical inpatients lagging behind the surgical cohort. There's a lot of reasons for that, of course. There's a lot of competing priorities, and I think from what I understand, your health system has taken some very positive moves recently to put this as part of their accreditation process. Some of this is lack of awareness. A lot of it's lack of buy-in and just competing priorities for the busy doctor who's trying to juggle 30 problems at once in a patient that comes into the hospital. Not many patients are admitted for DVT prophylaxis, so they're admitted for a multitude of other reasons. It's just not top on the list. So it's easy to forget. Until recently, there was a lack of validated risk assessment models. There are measurement issues around how do I measure DVT prophylaxis, how do I measure the outcome, and there were medical training failures and failure to use good QI framework. I used to be guilty of that until I got some more training. So I think using a good framework and being part of a collaborative can really accelerate improvement. A little bit about our local experience. We received an AHRQ grant, a federal government grant, to implement a DVT prevention protocol and make sure that it worked and to try to disseminate the results. We targeted all adult medical surgical inpatients. We used the VTE Risk Assessment Model that we tried to simplify as much as possible. Just basically put patients into 3 buckets of risk: low, moderate, or high. And for each level of risk, it was linked to appropriate options for prophylaxis. And we had standardized contraindications and leeway times. By leeway time, I mean, within 24 hours of most surgeries, within 7 days of spinal cord surgery. That's when you would expect somebody should be on anticoagulant prophylaxis if they had an indication for it. We integrated that risk assessment model into the order sets in such a way that it was hard to get around. And we tracked the adequacy of prophylaxis and hospital-associated VTE over time. It took us a while, but we went from about a 50% baseline as we built consensus up to 70%, as we implemented an order set, 80%, and then we started finding patients who were basically not on prophylaxis or not on the right prophylaxis in real time and giving feedback to the doctor in real time. And that really bumped our scores up into the 95% range, and they've been there basically ever since. When we accomplished this, it was gratifying to see the number of patients with preventable hospital-associated VTE plummet and the total number come down as well. A couple things to notice on this graphic is that the top lavender line shows all patients. The blue line is population. And at first, the medical population had more preventable hospital-associated VTE than did the surgical population. But as we pushed our protocol forward that was really where the biggest bang for the buck was, in the medical inpatient population. So I wouldn't negate the importance of that population. These are the total number. So, you're not going to prevent all hospital-associated VTE because, as the randomized controlled trials showed, you're going to with perfect prophylaxis and a randomized controlled trial, you're going to get maybe a 40 to 60% reduction. So don't expect to see zero. But we did see a quite significant reduction. As you can see, we went from 131 cases to 80 cases, and the number of cases at risk went up during that same time frame. Cases with PE went from 21 to 12. Cases with DVT went from 110 to 68. And the cases with preventable VTE went from 44 down to 6. We felt that this was the first real validated model for a risk assessment model, in that it was validated in practical clinical use. It was easy to use, had good interobserver agreement. It was predictive of VTE, that is, no one in the low-risk category developed a VTE. And implementation resulted in higher prophylaxis levels and lower rates of hospital-associated VTE. We put these lessons that we learned into a couple different guides, one of them being published by AHRQ, the other by Society of Hospital Medicine. And we started to put together some collaboratives around these toolkits. And at the same time, we modified our toolkits as we got more lessons from people who were using them. So they would give us tips that we would then incorporate into those toolkits. So it's now really been used in many, many different hospitals across a variety of different sites, including, I'm happy to say, that Dave Wilton and his group did a great job using some of these same lessons in British Columbia. And the Society of Hospital Medicine, HRQ, IHI, ASHP, they've all had initiatives that have focused on these same principles, and we'll be going over some of those. And I think, really, these are generalizable principles that can be used in a wide variety of hospital settings. The big picture is really to just take all the evidence and try to distill it into something that's simple, that provides that guidance at the point of care. Integrate that protocol with risk assessment into all admission and transfer orders, to the point where it's hard to get admitted to your hospital on an adult medical surge ward without going through the guidance of the protocol and without having the doctor see it and have to sign off on it. You have to monitor this. It's not, I put it out there and it's done. You have to monitor it, see how it's working, and then devise methods to detect those who aren't on the right prophylaxis and detect them in real time. That's different than what we are traditionally used to. We're used to seeing data from 3 months ago or 6 months ago saying how badly we did. But I think we need to shift towards, what are the opportunities for improvement that are here right today in our hospital. This protocol, as I said, is really the first intervention. It's a standardized VTE risk assessment linked to a menu of appropriate prophylaxis options. It also has a list of contraindications and what you should do in the case of those contraindications. And, you could write a 50-page protocol about this and hit every one of these points, but that wouldn't be of much use either, because it has to be easy to use and pretty much automatic to use. And, you have to always have this trade-off between how much guidance you provide and how easy it is to use when the doctor is actually writing the orders. I've seen lots of mistakes, and this is sort of a compilation or greatest hits, greatest things to avoid when you're doing your order sets. I think the main problem I see is that people make their order sets too complicated. They make a full-page standalone order set, or sometimes even a 2- or 3-page DVT prophylaxis order set. In general, those are going to be hard to integrate into your admission orders, and they're too complicated. The flip side is when you make it so simple that they're not really providing any guidance at all. I'll show you an example of that. And then sometimes people put out order sets without revising all the ones that are already out there. So then you get into dueling order sets and mixed guidance, and that can be a real problem. They try to put too fine a point on things and have 4 or 5 or 6 levels of risk, when really you only need 2 or 3. And then they often allow mechanical prophylaxis too often, I think. The testing for these order sets should be done in a real-world setting using real-world cases rather than just handing people an order set and saying, how does this look? In some cases, people try to put the risk assessment in the history and physical and then have the doctor write the orders remembering what that risk assessment was from 15 minutes ago or whenever they filled out that form. And that generally doesn't work as well either. I think this is an example of one that I think is probably too complicated. It's based on the Caprini model, and it's valid in terms of predicting risk, but it's really asking the doc to go through and, click a box here, and then click a box down here, and then click a box here, and then they come down here and they add up the points. They're supposed to read each one of these lines, right? And then they come down here and add up some more lines. They're supposed to read every line of this, and they're supposed to add up these points, come down here, and here's what the doctor does. Okay, I'm going to sign it, and they're going to click something, and they're not going to look anywhere up here. And that's what we see on direct observation when we go and look what happens at these hospitals. They basically ignore all the guidance because it's too complicated and takes too long. On the other side, this is just a listing of prophylaxis, and it makes it look like all of these are equal choices for all patients. So you get some improvement by just having this prompt, but a prompt is not a protocol. A prompt does not give you guidance. And so as far as doc filling out this form is concerned, this no prophylaxis line looks equally acceptable to this line of enoxaparin, and that's certainly not going to be the case. So we like simple risk assessment models with 2 or 3 levels of risk, and we think doctors should fill that out the first time, and it doesn't let nurses and pharmacists off the hook. They act as part of the safety net to capture when patients are not on prophylaxis. So I'll give you a little bit more example of that. This is an example of the risk assessment model that we like. It's got 3 buckets of risk. The cues are all in text, and the choices for prophylaxis are all right there. It's got the list of contraindications. The risk factors, most people know, we don't explicitly list them because it takes up too much real estate. So we like an audit strategy that's simple red, yellow, green. And you can do these other methods of looking at order set use and detailed audits, but we like this red, yellow, green strategy that's really simple. It's simple to do, it's amenable to automation, it's feasible. I think it's the way to go. So I'll give you an example of that. And this is how we use it for measure-vention. So we mentioned measure-vention at the top of the hour. That's basically when you measure something that can spur direct intervention at the same time you measure it. So these kind of reports can be used for both functions. And the idea is that the nurses would identify, or sometimes pharmacists identify patients on no anticoagulation or no prophylaxis, and they empower nurses to place mechanical prophylaxis if they're on nothing while they contact the MD after looking at a templated note to see if they're really there appropriately or not. Should they be on something? So, more concrete example. This is from one ward in our hospital. It shows everybody in the green is on anticoagulant, everybody in the yellow is on mechanical only, everybody in the red is on nothing. The orange means that they're on anticoagulant. The orange means that they're on mechanical prophylaxis, but that they have a known lab contraindication to anticoagulant prophylaxis. So what that means is basically if you can get this report in the hands of a nurse or someone on the front lines, they only have to pay attention to the people in the yellow and the red. All the people in the green and the orange, they can skip right by. And at the same time, you've got this measurement that says, well, I've got 24 out of 28 patients I know that are on adequate prophylaxis right off the bat. And then you do a script on these other 4 to tell you if they're appropriate or not. You can make these summary reports. Here's our contraindications we have in the labs. And then you can graph this out over time. You can graph it out by service. This is our measures across all service lines. So we have 70% of our patients on anticoagulant and mechanical prophylaxis, another 3 or 4% on anticoagulant alone. We have 10% on mechanical prophylaxis alone. We have, as you can see, we have less than 5% of patients on nothing. It's across all service lines, and this is for medicine. So you can see we perform even higher on medicine, I think. This is the script we use for the yellow patients. With our mechanical prophylaxis alone, we ask, are they low risk? And if they aren't low risk, we ask if they have contraindications, and we list the contraindications. If they aren't low risk and they don't have contraindications, that's a trigger to call the doctor or to leave a text page or however the institution decides to do it. You can come up with these summary graphs that tell you the percent with adequate prophylaxis, percent in red, yellow, green. And this shows you how well the measure-vention strategy works. You've got 3 wards with 70% prophylaxis. They've got good order sets in place. The arrow tells you where they started measure-vention, and you can see the impact happens quite quickly. So I guess the quick summary is VTE protocols embedded in order sets. Keep the risk stratification simple and text-based. Do it institution-wide if possible, although you may have to carve out a few services, especially like OB-GYN, sometimes orthopedics. Try to have some simple measures that you do regularly for VTE prophylaxis. Use measure-vention to accelerate improvement, and you're doing one thing right, and that's running a collaborative. I do see a couple quick questions. I'll just address a few of these. The patients who need both anticoagulant and mechanical prophylaxis, they are a fairly small group. It includes major orthopedic surgery like hip fracture and abdominal pelvic surgery for cancer for sure, and some people put ICU patients in that category. In terms of unfractionated heparin, 5,000 units TID versus BID and for hospital prophylaxis, the evidence is not perfect for that. And we use 5,000 Q8, but I can't tell you the evidence is great for that. I would pick one of those doses. I think TID is probably more effective, but I can't point you to great evidence saying that that's the case. And so I wouldn't build your risk assessment model on these patients are okay for 5,000 Q12, but these need 5,000 Q8. The evidence just isn't there to make that distinction. So I think I'll stop there and turn it over to Dave and the moderator, Sherry.
That's great. Thanks, Dr. Maynard. There were some other great questions that came up, and we will read those out during our question period at the end of the call. But right now we'll go to Dr. Wilton, who's going to talk about implementation and auditing strategies.
Thanks, Sherry. And thanks, Greg. Thanks for the great presentation and offering your time to come and share your experience with us. As everybody or many people know, Greg is the primary architect of the VTE improvement methodology that's formed the basis for most of the VTE improvement guides that many of us have learned from, and he's also led a number of collaboratives. So we really appreciate your support here. In particular, I appreciate your support in improvement initiatives I've been involved in. You may recognize some of the slides because not only did I plagiarize your methodology, I may have plagiarized some of your slides directly with your permission, of course. So my objective in presentation today is basically to very quickly touch on some of the highlights of the VTE protocol that was pioneered at UCSD, and then spend a little bit of time talking about auditing and reporting, in particular in the context of BC and clinical care management. We're a little bit short on time. I want to make sure that everybody has an opportunity to ask Dr. Maynard some questions, so I'm going to whiz by some slides, and I apologize in advance. We've already defined the problem well. We know that hospital-acquired VTE is common. Clinical consequences severe. There are safe and cost-effective means to prevent hospital-acquired VTE. Despite this, there's a significant gap in between patient care and scientific understanding, and our goal here is to make changes which will close that gap. And although the specific protocol is based on the UCSD protocol, many of the basic principles are very consistent with the IHI model for improvement, and I just wanted to bring that up to refresh everybody and remind everybody that this model involves defining what the problem is and implementing a change, testing that change, and repeating the cycle. And this is kind of what we're talking about with auditing and reporting today. Greg described the VTE intervention protocol very well. Basically, I think that the basis of the success of this protocol is that it forces physicians to risk stratify patients for VTE prophylaxis at the time of admission and transfer. And it provides decision support at the point of care, linking to appropriate prophylaxis options. And when you're successful in embedding this protocol in the workflow of physicians, then VTE prophylaxis is no longer overlooked, and the correct decisions are made. I thought it would be useful to show some protocols that are currently in use in British Columbia. Right now I've got projected a standalone regional protocol used for medicine in coastal health. And you'll see that it's got all of the elements that Dr. Maynard's protocol calls for, including a risk assessment, and it lists contraindications to prophylaxis, and it provides a menu of options for anticoagulant prophylaxis. Now, this is a standalone pre-printed order set that's intended to be used in addition to other order sets or handwritten orders in coastal. And the decision support is on the back of the page. It's probably busier than one would like, but because it's a regional-wide order set, I think that it was felt that it should be as comprehensive as possible. What I've got projected right now is an adaptation of the UCSD protocol that was used by the Hospitalist Collaborative in British Columbia. As you can see, this format of the protocol is much more compact, and therefore it's more amenable to being inserted into pre-printed order sets. And I think that the ideal intervention is to have VTE protocols embedded in the workflow of physicians so that they don't get overlooked or they don't have to go and look for an additional sheet of paper. Similarly, this protocol asks for risk stratification. It has a menu of prophylaxis options, and it lists contraindications to prophylaxis and what to do about them if you have them. And the decision support is actually provided in text, right embedded within the protocol. So the big question here is, how do you get the protocol in use? This CCM initiative is province-wide, so it's actually quite a large implementation project covering multiple health authorities with obviously multiple hospitals and multiple physician services within each. So this is the essence of the challenge with VTE implementation, is that it cuts across all specialties, and there isn't a particular physician group or administrative hierarchy that you can push this thing through. So, ultimately what has to happen is the improvement leaders need to engage the physician services program by program. Ideally, they would embed the VTE protocol within the preprinted order sets of the programs. In some cases, it may be necessary to use standalone preprinted orders, particularly for those programs that do not yet have order sets in place. And just as a suggestion, one might consider starting with high-volume services like medicine or the hospitalist services, or high-risk populations like orthopedics or general surgery, or focus on low performers, which happen to be medicine and non-surgical specialties. Ultimately, the goal is to get VTE protocols embedded in all admission and transfer orders for all services. And I guess the primary argument you make with the physicians is that preprinted orders can streamline their work and improve the quality of care they provide. And we certainly experienced that with the hospitalist collaborative, whereby preprinted orders that were designed that did not streamline work were never used and never implemented. And our greatest successes were with those programs that actually found that the preprinted order set made their lives easier. So I'm going to move on to performance tracking. This is one of Greg's slides. I imagine this is in your neighborhood in San Diego somewhere, Greg. I think it makes an important point. You need to know where you are in order to know where you're going. So it's very important to have an audit protocol as part of your implementation strategy. And primarily, the reasons for this is that it identifies gaps between evidence and practice. And it provides a lot of important data that is useful in subsequent PDSA cycles to improve the care process. And bottom line, data is a very powerful driver of change in practice, and people respond to data. So I think this is an essential element in your improvement strategy. Typical measures for VTE implementation include process measures, which look at measures involved in the process of getting appropriate prophylaxis to patients, and outcome measures. At this point, it's challenging to acquire accurate outcome measures based on our current clinical data systems. We're hoping that improvements in the coding system and our IT systems will make it possible to efficiently collect outcome in the future, but at the moment it's cumbersome because you have to do chart audits on every chart. For clinical care management, the measure that we have asked that health authorities report on a regular basis is the percent of adult patients receiving appropriate VTE prophylaxis, and appropriate being defined as consistent with 2008 ACCP guidelines. We feel that this is a process measure that is basically the sum result of multiple care processes, and it's as Dr. Maynard has demonstrated, improvement in this process has been directly linked to an improvement in patient outcomes. The audit methodology that we're recommending is based on Dr. Maynard's work, and it's a prospective chart review. This, as opposed to a retrospective chart review, which may be a choice that some people would have wanted to make, but we believe that the prospective audit methodology provides a snapshot in time, which actually captures a composite of all the care processes. It allows you an ability to see rapid results for QI efforts and allows you to do rapid PDSA cycles as opposed to waiting for the charts to go through the coding process and doing retrospective analyses, which you would end up 3 to 4 months down the road before you'd probably get your data fed back. As Dr. Maynard outlined, if you automate this process and take it one step further, you can prospectively increase your prophylaxis rates up to 98%. For clinical care management, the sampling strategy that's recommended is that hospitals that have less than 100 beds will need to audit 100% of their patients each period. Hospitals that have more than 100 beds will be asked to audit 100 charts per period. And we've asked that the data be stratified by medical, surgical, and critical care patients. And I would recommend that you try and keep the proportionate distribution of your audits similar period to period amongst the three groups, so that what you're actually seeing over time, one period is comparable to the next, so that you can actually track your progression. I just wanted to, I'm not sure if this metaphor is perfect, but I wanted to make the point that we shouldn't design our improvement strategy purely for clinical care management data reporting. I think that there's a lot of other very important process measures and possibly different sampling strategies that will need to be employed in order to achieve your improvement goals. It's true that I think that we're hoping that the percent of patients appropriately prophylaxed will give us an accurate indicator of how well things are doing, but it's designing your entire protocol around that measure alone, I don't think is going to get you the results that you're looking for. So there have been a lot of questions as to how to design an audit methodology. Basically, I think anybody with a reasonable healthcare background can do the audits, and I'll show you that the audit tools can actually be fairly prescriptive, so there's not a lot of autonomous decision making. Some recommendations. The audit tool should very closely mirror your VTE protocol, and this will allow decision support at the time of audit, and it will ensure consistency if there's more than one auditor involved. And we came across that problem. We didn't prescribe enough, so we didn't provide enough guidance with the initial round of audits with the hospitalist collaborative, and found that the audits were probably not accurate. So very quickly, I'll just cover the areas that should be looked at in the audit outline. And basically, you want to determine if a patient meets exclusion criteria. If they meet the exclusion criteria, then you shouldn't proceed with the audit, and their data should not be included in the CCM data that's submitted. Some of the questions to ask, is the patient low risk for VTE? If so, then they do not require VTE prophylaxis, and no prophylaxis would be appropriate. Does the patient have contraindication to pharmacologic prophylaxis if they are moderate to high risk? And similarly to mechanical prophylaxis. And ultimately, you want to determine if prophylaxis is appropriate, whether they've been prescribed mechanical or pharmacologic prophylaxis. And I've got a couple of examples of audit tools just to show you how the questions are linked to the VTE protocol. In fact, this is the audit tool that we used with the BC Hospitalist Collaborative. And you can see that this box here is essentially our VTE protocol. But we asked the auditors to basically, for each patient, to work through this protocol, which ultimately assisted them in answering the questions below. So first of all, if the patient is excluded, then they don't need to do the audit. Secondly, if they're low risk, then they would be early ambulation, and you would check to see whether or not they had pharmacological prophylaxis ordered, and if they did not, then you would say that current prophylaxis is appropriate. If they were moderate to high risk, you would select what you believed was the appropriate prophylaxis regimen, and then follow the questions through, determine whether or not prophylaxis is appropriate. Similarly with mechanical prophylaxis. This is the UCSD VTE prophylaxis audit data collection form. Thanks, Greg, for sharing that with us. And as you can see, they've got a similar methodology in that they ask all of the questions, and then they do a final analysis. Is prophylaxis adequate or not? And on the back side of their audit form, they provide all the decision support that allows an auditor to refer to it so that they have consistency. And lastly, I just wanted to talk about how you need to disseminate the data if you want actually to have your audited data promote change. There's many ways to do this, but some suggestions include breaking the data down by hospital, by doctor service, or by ward, and discuss the results with stakeholders. And don't be afraid to draw conclusions and target your message to the various stakeholders. Some places have considered posting results on the wards or on their website, or even publishing it in a newsletter. Public accountability can be a strong motivator. And lastly, I would use run charts, and we've already seen one of Greg's run charts to show incremental improvement. This is one from Vancouver General Hospital Hospitalist program. As you can see, our prophylaxis rates were less than stellar prior to we implemented an awareness program in the about VTE prophylaxis, and we're able to maybe budge things up 10 to 20%. And when we put the pre-printed order set embedded into our workflow, we showed rapid improvement. And this is a nice way of showing historical improvement and reinforcing the gains that you've made. Once again, thanks to Greg. This must be San Diego basic training, but the point here is that we're here to help if nobody ever gets this correct the first time. And there's a number of resources. There's some national collaboratives that people can join, and Shari and myself are more than happy to provide support in any way that you think is useful. And lastly, here's our website, and we've got several resources on the website that you can refer to for guidance.
Great. Thank you, Dr. Wilton. That was great. So we've had a few other great questions come up in the chat feature, and we wanted to allow a lot of time for questions, so we will extend our call as needed to answer them, hoping that all of you can stay with us during that time. So the first question that came up, I think, is a good one to redirect to Dr. Maynard. And the question is, I was under the impression that we either use low molecular weight heparin or mechanical measures and not both. In this presentation, there is support for using both chemical and mechanical at the same time. You mentioned colorectal surgery is the highest risk. Are there other groups where we should consider using both?
Well, as I mentioned, I think most people are fine with anticoagulant alone. The people who I would consider using both on, or that have the strongest evidence for using a combination, include patients like hip fracture hip fracture repair and hip replacement patients, knee replacement patients, abdominal pelvic surgery, especially for cancer. And again, I think some people place a lot of their critical care patients in this category. We don't have as much evidence for that patient group, but there likely is some incremental benefit, and the downside if you use sequential compression devices might be fairly low. No matter what device you use, if you're using mechanical prophylaxis, you have to pay attention to whether or not they're on and if they fit properly, because there is some downside in some settings. That is, you can imagine And we've seen in some studies some ulceration of the skin, some problems like that. And, they act, Foley and SCDs act as three-point restraints. So you don't want to retard the very ambulation that you're trying to encourage by having sequential compression devices on unnecessarily. But I think those are the patient populations I'd really consider, and the highest of the high risk. We actually use it for a broader range of patients, and that predates me. We had mechanical prophylaxis protocols in place when I arrived here 9 years ago, and most of our patients actually are on both. We're actually going about the process of changing that because I think it's probably overly aggressive and a waste of some taxpayer money that we don't need to spend. But I would certainly consider it for that subset with major orthopedic surgery and abdominal pelvic surgery for cancer.
Great, thank you. Another question that came up was from Denise. Has anyone revised their recommendation for VTE prophylaxis based on the results of the PROTECT study? Dr. Maynard, are you familiar with that study?
I'm not sure. I think that's a UK or Scottish study for unfractionated heparin versus low molecular weight heparin in critical care patients. Maybe I saw the Bill's on the line. Maybe Bill can help me out here. But as we discussed earlier, I think the low molecular weight heparin versus unfractionated heparin to me, is less of an efficacy issue and more of a convenience issue, cost issue, and HIT prevention issue.
Okay, we're going to unmute the line of Denise if you wanted to speak further to that, and maybe Dr. Bill Geertz if you're still on the call as well.
I can just say a couple words on the PROTECT study. Thanks very much, all of you, for a great presentation today. I really enjoyed it, and it always is reassuring that other people are leading in this area, and it really helps us keep going. The PROTECT study was a multi-center, multi-country study in critical care patients, Greg, as you quite rightly said, comparing low molecular weight heparin and low-dose heparin, and it basically showed equivalent effectiveness from the perspective of VTE, and it showed equivalent bleeding. And only at the secondary outcomes were there any differences between the groups, and obviously we have to have limitations around how we interpret that. There were statistically fewer pulmonary emboli in the low molecular weight heparin group than the low-dose heparin group, and there were numerically 50% lower hit rate with the low molecular weight heparin than heparin, which would not be surprising. Should that study change practice? I think it validates in some way the use of low molecular weight heparin and low-dose heparin in ICU patients. I think we need to keep in mind that these ICU patients were at the low end of the risk spectrum for ICU patients because high-risk patients were excluded. So trauma, orthopedic surgery, neurosurgery, cardiac surgery patients were all excluded from this trial because there was other evidence available. So like in some other moderate risk group of patients, like general surgery or medical patients, low-dose heparin and low molecular weight heparin are pretty similar in efficacy and safety. And as Greg said, there are other issues that are important in making that decision, like the convenience of once-a-day dosing, the reduced risk of heparin-induced thrombocytopenia, and the fact that one can use low molecular weight heparin across the spectrum of hospital patients. So the PROTECT study is consistent with what we were already doing.
Great, thank you. Denise, did that fully answer your question?
Yeah, Sherry, that's great. I just wondered if there were people out there that had made any practice changes based on the results of the trial, seeing that the two drugs were seen as somewhat equivalent in the sort of low-risk populations because, of course, the high-risk ones were excluded. But there was the reduced risk of PE, I thought that perhaps those who may have seen the drugs as equivalent in the past may lean more towards the low molecular weight heparin in the populations that were included in the study.
Great, thank you.
Well, just on a personal note, we lean that way ourselves. We list it first as the first option, and we use it in the majority of our inpatients. But we do offer the option, which gets chosen predominantly in patients who have renal insufficiency.
Thank you.
That came up for Dr. Wilton during your talk. How do you feel about an even simpler risk model? Yes versus no.
Well, it depends on the population, and I don't know if you can see the slide that I've backed up to, but this basically captures the BC collaborative risk model. And as you can see, we actually did collapse this essentially into a binary decision because we don't have a lot of the high-risk groups in our medicine population. So we basically simplified it as much as possible and said they're either low risk and don't need prophylaxis, or they're moderate to high risk. We did leave in the opportunity to use combined serial compression devices and pharmacologic prophylaxis in the moderate to high risk group, but in practice I don't think that we have the patient population that requires this. So yes, we simplified it based on our patient population, but I think that there need to be minor tweaks based on the patient population that the protocol is designed for.
And I think that you use the simplest one that works for your population. So I'm in full support of the yes, no, or what I would call the two-bucket model when you're dealing with only a ward medical population. It's when you start dealing with, orthopedic surgery, multiple major trauma, abdominal pelvic cancer surgery, and perhaps critical care that you'd want to use some combination, or in which you'd want to maybe mandate low molecular weight heparin versus unfractionated heparin, and in which you'd want to encourage a combination of those agents.
Great, thank you. So we're now in the portion of the call that we have a few minutes left. If you have another question, please raise your virtual hand. So just click once on the hand icon, and we can then unmute your line and you can ask your question. Are there any other questions for Dr. Maynard or Dr. Wilton?
I think I see Niall Higgleson's hand up.
Go ahead, Niall.
Hello. My question is around the prospective auditing and how to cue the physician's attention to perhaps a missed opportunity to use prophylaxis. Currently at our site, what we're in discussion of doing is one way that we currently flag physicians is to raise whatever sheet needs to be completed within the binder. And just wondering what other sites have done to bring physicians' attention to that.
Greg, I think you're well down that road. Do you have a...
Yeah, I'll give you a couple things that we commonly advise. First, you can start the measurement piece anytime, and the earlier the better. Before you start calling individual physicians, you shouldn't start that intervention piece until your order set's in place and the protocols have been distributed. Otherwise, you're going to be calling up 80%, you're going to be trying to call on 70% of your patients. If we go back to the slide where Dave showed his progress, Dave, maybe you could put it back on that slide. Then you'd be calling too many people, you'd be having alert fatigue, you'd be wearing out your nurses and your doctors. So, I would recommend that you get your order set in place, make sure the protocol is well known, have your prophylaxis rates up in the 60-70% range before you start doing the intervention piece where you're calling people. And then try to reduce the number of false alerts by having that screening to just make sure that if they're on nothing, that you at least ask, are they low risk, and have that definition there. And, you know, do they have contraindications, at least the most common obvious contraindications that would be known to a nurse. So, you know, if you're calling up a doctor and saying, why don't you put DVT prophylaxis on this patient, and the patient's got a central nervous system bleed, you're going to make somebody mad instead of help the situation. So have a common script to triage those, and how exactly you go about it, I think, varies by hospital, but for most places, they will put in a text page, and then if there's no response, they'll do something else the next day, or they'll put in a text page and leave a templated note on the chart.
The one question that raises is then once a protocol is in place, our local protocol is to have the risk assessment completed for every patient. So we would expect to see the PPO on every chart. From what you're saying, I'm wondering if it's a low-risk patient, should we require the PPO on the chart still, or should
here, it sounds like what you're having, like you're having the nurse do the risk assessment and presenting that to the doctor on every single patient. And that's not what we recommend, because you see people get fatigued and often ticked off by it because they've already ordered prophylaxis. So why are you handing me this piece of paper? So in this technique, you allow the time and the opportunity for the doctor to get it right the first time. And then the nurse or the pharmacist only focuses on those patients who are not on anticoagulation. So, you know, you're focusing your attention only on those who are in the yellow or the red, so to speak. Does that make sense?
Yes, it does. Thank you.
There was another question that came up from Dennis Cleaver. Dennis, we'll unmute your line so that you can ask your question verbally.
Sure. I'm just wondering whether or not there's a hospital policy guideline decision support tool, depending on the language you use, that would be easy for us to start with so that we're not starting with a blank page and developing the VTE document and pre-printed orders for our hospitals?
In terms of the order sets, I think you've seen sort of some of the guidance for order sets, and Bill Garrett's, I think, showed you sort of this group last time. He has an even simpler model, I think, that's basically you're on prophylaxis unless you say why you're not. So another version is sort of the two-bucket model. In terms of policies and how to put that together, I think there's a nice toolkit that's on a website called HSAG, or Health Services Advisory Group. It has, I can show you where that website is if I don't know if you can see my screen, or I can just give you a website where you can go find it.
Well, maybe while you're doing that, maybe you could even type that link into the chat if you're able to, Dr. Maynard. And
yeah, let me make sure I've got it right here.
What I was in part thinking, I forget which hospital Dr. Wilton is with, but if you have this already salted away, whether it's easy to share your health authorities' guidelines and other materials with us?
Yeah, I was going to point you to the CCM or the BC Patient Safety and Quality Council website, and maybe, Shari, you can type the URL into it. We have a resource page, and if I'm not mistaken, I think that we posted the Vancouver Coastal policy on the website. I think they gave us permission to share it, and that has some pre-printed order sets. The other place I would point you to probably is the Safer Healthcare Now VTE Prevention Guide, which is right at the top of the resource page, and that's sort of a step-by-step introduction into how to do it, but in the back of that, they have a number of examples, particularly stuff from Sunnybrook, where Dr. Gertz is from, is quite useful.
Thank you.
That's correct, Dr. Wilton. We are gathering up a lot of resources now and have them available on our website, www.clinicalcaremanagement.ca, and I've just typed that web link into the chat feature, so you'll all have it. We will also post a recording of today's call on our website under the VTE events page as well, so you can look for that link to that recording next week, so you can go back and review if needed. Are there any other questions before we move on to the last bit of the call? And I don't see any other virtual hands or questions coming up in the chat. Maybe we'll just quickly open up the phone lines. Is there anybody who's on the phone and wasn't able to connect through computer that has a question now? Okay, great. And I see that Dr. Maynard has directed you to go to stopvte.org and click on the resource room menu on the top right. And there you'll find a variety of resources, including the Health Services Advisory Group, which focuses on policies. So thank you for that. So just before we close up then, I would like to direct you to our next webinar, which is scheduled for February the 14th at 1:30 p.m. And that's looking into one of the required organizational practices for VTE prevention, which is educating nurses and caregivers. So we're hoping to have some teams sort of discussing how they're approaching that in British Columbia and how they're meeting that ROP. So I encourage you to attend if you can and share that with your colleagues. So go on our website. You can sign up for our newsletter, which will inform you of any more upcoming webinars that we host. Also like to direct you just to some quality improvement resources in general, www.impactbc.ca, which is the local British Columbia organization that will help you develop your quality improvement expertise, and they've got lots of tools and training available for that. And then lastly, just to show you a screenshot of our website, clinicalcaremanagement.ca, and here you can find lots of resources that we've mentioned today. You can sign up for our newsletter. You can access our contact information for myself and Dr. Wilton as well, so that you're able to direct any other questions to us, and we can then direct them on to our presenters today. You can also download the clinical care management guidelines and the measurements for VTE prophylaxis, and more details about the key reportable measures, other events coming up, and tools, etc. Like I said, a recording of today's call will be available on this website under VTE events. And that concludes our session today. Thank you so much, everybody, for coming. I really do appreciate it. Your computers will now direct you to an evaluation form after we close up the call, and I'd encourage you to fill that out. It really helps us to review your feedback and improve our future learning sessions. So thanks again very much for coming, and have a great day, everyone.
Thank you. Thank you.